Next is Dr. Searle, who will talk about how much medication is too much now that we have so many options, talking about third, fourth, and fifth drug use and delaying surgery.
Good morning, Joe, Albert, colleagues, friends. There are a series of questions associated with this session. We'd appreciate if everyone respond to the questions. We will talk about them at the end. And also, if anyone has any questions, please submit them. Albert mentioned the title of my talk. My financial disclosures are all in the pharmacology realm. So now there are 7. What a great boon for us as treating clinicians and for our patients. And the dosing of these medications ranges from once a day to 4 times a day. So the question we're all asking ourselves, what is maximum tolerated, effective, and reasonable IOP-lowering medication regimen? We have a great deal of information about medical therapy. There are many evidence-based facts. We know if you add a second, third, fourth, et cetera medication, you don't typically anticipate or get as effective a pressure reduction as if you're using that drug as first line. We know the duration of a third, fourth, et cetera medication may be less than when used as a solo agent, and the efficacy tends to wane over time. There are many factors that reduce compliance, particularly the complexity of a medication regimen. We worry about nocturnal efficacy, which is less with some of our medications, and our patients may be progressing during the nighttime. Interday and intraday fluctuation have been evaluated in many studies. These factors may contribute to progression, and there actually is at least one literature review that suggests that a combination drug may decrease these fluctuations. Conjunctival changes from chronic medical therapy are an issue that we all face when we go to operate on patients, and we consider, should we stop the medication, should we add steroids, or should we cross our fingers and high dose of steroids post-op? And we know if you give enough medications for long enough, the ocular surface won't look so nice, and the patient will start complaining of blurry vision. So we know all the caveats related to medical therapy. How do we practice? Well, in the early 1990s, the AEGIS trial was conducted, and this is before the introduction of prostaglandins, topical CAIs, and alpha-adrenergic agonists. The mean number of baseline meds in that study was 2.7. Mid-1990s, those 3 classes were approved, and you can see the subsequent large-scale clinical trials had baseline number of meds of 3 or greater. More recently, in peer review articles, we see mean baseline meds as high as 3.6, and in CME publications with case reports, we see medications as high as 5 in an individual patient. So what's the evidence for adding a third or fourth medication? There aren't a lot of studies, but I'll go through what we've got. So rapacidil is a rho kinase inhibitor administered twice a day, available in Japan. When patients were dosed for 12 months, there was an additional 15 to 16% reduction of pressure in over 2/3 of patients. And those patients started with a baseline number of meds of 3.6, so a large number. Notarsidil, that most of you are probably familiar with, is the rho kinase inhibitor that was approved in the US in 2017. There was one 3-month retrospective study that shows additional pressure reductions of about 4 millimeters of mercury. And it didn't matter the number of medications patients were taking. That was, the reduction of IOP was similar if you were on less than 3 meds or 3 or greater meds. Brimonidine has been shown to be additive over 12 months in about 50% of patients on baseline of 3 meds. And there are many studies that show latanoprost is additive. So there certainly is evidence that third or fourth drugs do add. We don't have long-term evidence, but we know they work. What's been a game changer in the last 2 years or so are the fixed-dose combinations, because fixed-dose combinations address all the caveats mentioned in an earlier slide: compliance, cost, complexity of regimen, IOP fluctuation, ocular surface disease, et cetera. So we have the list here. We have several options. So the question I'm going to pose to you is, should we be counting the number of medications, the number of bottles, or the number of daily eye drop installations? So I put together this chart looking at how many drops you need a day, how many bottles would translate into the number of meds. And you can see that you can dose 5 medications with only 4 bottles. When you think about our days of pilocarpine, we were dosing 1 medication 4 times a day. Now, not all of our patients are going to tolerate 4 doses or 4 drop installations a day. You have to determine what an individual patient can tolerate, but we can logistically dose 5 medications with 4 drops a day using our fixed dose combinations. Can patients do this? Yes, we all can think of patients in our own practice who dose medications 3, 4, 5 times a day reliably and comfortably. And if that patient is stable and comfortable, we maintain it. If there are issues, we need to either simplify the regimen or move on. So I think we all know the red flags as to when it's time to move on from medical therapy, be it 1 medication or 5 medications. The "I'm going to do better, doctor," that's a red flag. Gotta go on. Marked variability and pressure from visit to visit. Maybe that patient has intrinsic large fluctuation, but most probably they're not always taking their eye drops. The patient who always runs out of or doesn't refill their drops, move on. Or the patient who really doesn't show up in your office when they should, another red flag. So does the use of the 3rd, 4th, or 5th drugs delay surgery? Well, we have data that additional medications do lower IOP, so that should translate in some patients to surgical delay. How much medication is too much? There's no magic number for medications. One patient's treatment sweet spot is another patient's treatment burden. So the maximum number that is effective certainly varies markedly. And the most efficacious and best tolerated combinations are unlikely to be uniform for all patients. So make sure your target pressure is achieved, the disease is stable using all the technology we've seen earlier today, that the patient is truly adherent, and that then translates into the correct regimen for an individual patient. Thank you.